Thank you, Dr. Stern, for the invite. Honored to be here this morning. I will be speaking on radiologic perspective on micro-ultrasound. These are my disclosures. So what is micro-ultrasound? Micro-ultrasound is a novel ultrasound-based system which operates at a much higher frequency compared to the conventional truss ultrasounds that we have used in the past. It is nothing but an ultrasound device and is consistent. The procedure and the workflow is consistent with traditional truss setup and technique. It operates at about 29 megahertz, and as I said earlier, which is compared to the conventional 6 to 9 megahertz transducers that we have been using in the past, it provides 300% higher resolution than the conventional truss, down to 70 microns, the size of a prostatic duct. And has 4 times the density of ultrasound crystals, 512 crystals as compared to 128 with conventional truss over the same space, which then provides for improved lateral and axial resolution when using the micro-ultrasound. And it utilizes the Primus Protocol to identify and target suspicious areas seen on the imaging. Now, what is the Primus Protocol? So we have discussed about this in the past meetings as well. Early on in our RCT, the multi-center RCT, which was conducted a few years ago now, we realized that there was a steep learning curve to interpret and identify what cancer looks like on this new novel micro-ultrasound, the high-resolution ultrasound. Cancer was not always hyperechoic, as we had previously learned on using the conventional truss ultrasound, but could be seen as different appearances like echogenic or an area of mixed echo lesion. So based on our experience in the initial RCT, we developed the Primus Protocol. And at that time, what we were doing, we were just trying to emulate the PIRATS scoring system, which has been developed for MRI. A score from 1 to 5, a higher score in the Primus Protocol, very similar to the PIRATS protocol, meaning that there is a higher likelihood of that ultrasound pattern to harbor clinically significant cancer. And that allowed us to more accurately target the sites which we thought could be suspicious at the time of micro-ultrasound imaging. But if you look at the Primus Protocol, it does not address identification of targets in the transition zone. And one would think that with the use of a higher resolution device, the farther you go, the increased height from the rectum, you'll perhaps lose some of the advantage of the high resolution that one may have at a greater distance from the probe itself. And there are new software which kind of now help to extend the benefit of the high resolution to the anterior gland as well, so that there is still a benefit of assessing targets in the anterior transition zone when you compare it to the conventional truss ultrasound. But at the same time, I would like to highlight and mention that in a few instances, you might get dense calcification in the transition zone or the side of the surgical capsule, or dense corpora myelacia, which will then cause shadowing and may limit assessment of the anterior transition zone. So we have started working and are beginning to understand how transition zone or anterior zone cancers may appear on micro-ultrasound. We have been looking at RAT-P studies as well as MRI-targeted biopsies, and some of the lesions appear such as hypoechoic finger-like projections or a storm cloud appearance, has shown to have an increased association with prostate cancer in the anterior transition zone. We hope to validate and develop the second version, I would say, of the Primus Protocol, which would then include assessment of the anterior transition zone as well. So moving on to cancer detection with micro-ultrasound, there is mounting evidence over the last, I would say, 3 to 4 years now, that it is much more sensitive than conventional ultrasound in detecting or identifying significant prostate cancer. So apart from our initial RCT, which compared conventional truss to micro-ultrasound, there have been more recent publications as well, which have again concluded that micro-ultrasound finds more cancer as compared to conventional truss. higher incidence of grade group 2 cancers or higher are detected on micro-ultrasound as compared to conventional ultrasound. And in this study, published a couple of years ago, they found that the clinically significant cancer rate detection increased from about 12% to 45% when using micro-ultrasound targeted sampling, and was a huge benefit over conventional truss imaging. A recent meta-analysis also showed that micro-ultrasound provides high sensitivity, close to about 90%, and a significant diagnostic value, despite, I would say, a relatively lower specificity, uh, especially when it is compared to MRI. So, very high sensitivity in detecting clinically significant cancer, repeatedly shown over many studies over the last few years. Here's a study done out of Charité Hospital in Germany. They looked at the additional benefit of micro-ultrasound to the MRI pathway. Enrolled 159 patients in this study, and they found that in 17% of men with a negative MRI, targeted micro-ultrasound biopsy detected cancer. In 13% or 20 men, MRI were negative, but micro-ultrasound targeted biopsy detected clinically significant prostate cancer. So again, showing a benefit of adding micro-ultrasound to the MRI pathway. And in addition to that, they also found that in 16% of cases, or in 24 men, the micro-ultrasound target site actually detected the highest grade group or the highest grade cancer in that patient. So there was definitely an additional benefit of adding micro-ultrasound to MRI. And with all the evidence that is coming out, a recent meta-analysis was published earlier this year, which showed that micro-ultrasound provides equivalent sensitivity for detecting clinically significant cancer compared to the MRI targeted biopsy. Again, showing that it is sensitive and perhaps close enough to MRI in detection of clinically significant prostate cancer. But if you look at all the studies, and if you go back and look deeper, many of these studies did not mention or did not specify the MRI acquisition parameters, were performed unblinded to the MRI results, and there was a risk of bias in many of these studies. So we have recently completed accrual in a 100-patient prospective registry-based trial comparing MRI to micro-ultrasound. Micro-ultrasound assessment was blinded to the MRI. MRI acquisition and interpretation in our study was performed as per the minimal standards set by the pilots committee. And the aim of our study was to compare the two modalities in detection of clinically significant cancer as well as detection of the insignificant cancer. We looked at biopsy avoidance using both the pathways independently. And if there was any role of additional benefit of adding non-targeted systematic sampling to MRI and micro-ultrasound targeted biopsies. Cribriform and intraductal cancer, we know are histologic parameters associated with adverse clinical outcomes, and we looked at the detection rate by MRI as well as micro-ultrasound in a blinded fashion in our study, comparing the two modalities. And we also looked at MRI lesion visibility on micro-ultrasound. We have completed accrual. We hope to have the results of our study in the next few months, and should be able to share soon with the prostate community at large. So apart from increased sensitivity of micro-ultrasound in detection of clinically significant prostate cancer, one of the other advantages of micro-ultrasound is it allows for real-time targeting, because many of the MRI lesions are visible on micro-ultrasound at the time of the biopsy. In this study performed by Dr. Salas Sanchez's group in Paris, a significantly higher detection rate was seen on MRI-targeted biopsies when using micro-ultrasound guidance as compared to when they used robotic elastic fusion for targeting. And this can only be explained by the real-time visualization of MRI targets by micro-ultrasound. We know that truss visibility of lesions facilitates targeting. And in another study, which was done by Dr. Cornu, again in a different hospital in Paris, they found that with the prior knowledge of MRI and way to expect to see a lesion, 90% of the MRI lesions were visible at the time of micro-ultrasound biopsy. So This really allows a targeted approach or a real-time targeting of the lesions as compared to utilization of a fusion device to target the site question on MR. And they found that once the lesions were visible at the time of biopsy, about 61% of those lesions harbored clinically significant prostate cancer. And compare this to the literature uh, published previously, where we know that about 40 to 50% of the MRI lesions may be retrospectively visible at the time of conventional truss and fusion biopsy. So, on one hand, when you're using conventional truss, less than half of the lesions would be visible for targeted biopsy, and you're relying on the fusion software. But with micro-ultrasound, close to 90%, of course, with the prior knowledge of where to look or where to find the lesion that was in question on the MRI. And that's a hugely significant advantage of micro-ultrasound for targeting as compared to conventional truss with fusion. And in the same study by Dr. Konu and his group, they found that 114 of 144 lesions that were in this study, 114 of them were visible both on MRI and micro-ultrasound. And of those 114 lesions, that 62% of the lesions harbored clinically significant cancers. There were 13 lesions which were visible only on MRI but were not seen on micro-ultrasound, and none of those sites harbored clinically significant cancer on targeted biopsy. While additionally, there were 17 lesions visible only on micro-ultrasound but were not called prospectively on MRI. And 4 of those sites did harbor clinically significant cancer, again highlighting the benefit of adding micro-ultrasound to the MRI pathway in detecting clinically significant cancers. I'll show you a few examples of how cancers look like, the different appearances on micro-ultrasound. Here's a patient who had a smudgy kind of an appearance here in the mid-gland to apex of the peripheral zone, and on targeted biopsy harbored 3+4. So again, you can see the hypoechoic, smudgy kind of an appearance there in the peripheral zone. Another example of a very markedly hypoechoic lesion in the mid-gland to apex of the prostate gland harbored high-volume Gleason 6 disease on targeted biopsy. Thank you so much, and I'll be happy to take questions.